So let's go to the next case. So yeah, the main thing I wanted to illustrate is obviously benign versus aggressive versus non-aggressive. You can't really see benign. So aggressive versus non-aggressive, and also illustrate to you guys the point that these exostoses can actually get they can actually get a sarcomatous transformation, but just because sometimes people have pain, but it doesn't mean they've got sarcomatous transformation. Sometimes they've got pain because of a local mass effect that can happen in these lesions. Right, so this one, I'm going to just open up and you guys can have a quick look and see what you guys think. So yeah, so this patient's fallen on their outstretched hand, and they're coming in with a lot of pain. So those of you that are regular to my talks, I have talked about this kind of thing before. And so what you can see is when you've got adult patients, generally speaking, when you looking at the elbow and they've had these traumatic events, the main place to look is going to be the radial head, and that will actually become more appropriate for a later case that someone else has brought in for me to look at this week or this month. And so the radial head is usually the place that you get injuries. And so when you've got injuries, you've got to take a really close look at the radial head in an adult patient. But when you've got a pediatric patient, it's not going to be the radial head per se. You're going to be looking at the supracondylar region. Now, the reason I think that the radial head gets affected more than anywhere else in adult patients is that when the patient falls over, what ends up happening is you get the forces going right straight through the radius. So at this end, the largest part of the wrist is going to be the radius. So that absorbs a lot of the weight, and that goes all the way through, translated all the way through to the elbow, and then comes across to where it actually becomes thinner and thinner and thinner. And then all that force, brute force, get hit right on the end like a hammer, hits in the capitellum, and you get what is known as a fracture of the radial neck or the radial head. And so in this particular occasion, what you can see, hopefully, is a fracture of that radial head. If we draw a line like so, you can see a radiolucency like this, radiolucency like this, and it goes along like so. So what's important about this one is that there's intra-articular surface involvement. So we don't say the tip of the radial head. We just say there's a radial head fracture with intra-articular surface involvement as well. So obviously, you know, being a radiologist and someone who's working in healthcare, you also do want to make sure that you do have a look at the capitellum. Make sure there's no evidence of any fractures there. Sometimes you can get a secondary osteochondral defect or fracture because of the impact that happens when that radial head hits that capitellum. Also, the sagittal views, let's have a look and just see to confirm what we're thinking. You can see on the sort of the more sagittal views of the elbow, that radial head fracture is not as obvious. But in this view, you can actually see a lot of that joint effusion. You can see a joint effusion there, and you can see this hyperdense material sitting over there. So it's probably a bit of blood that's kind of extruded out of the fracture, and you can get to see the sort of bowing of the joint capsule over there. Now, again, for those of you that have kept up with my talk before, sometimes you may have a fracture that is just slightly outside of the joint capsule, maybe in the radial neck. So you get a fracture over here, and because it's outside the joint capsule does not have any evidence of any effusion, right? So you actually have no effusion, no posterior fat pad elevation, but what you end up having is a fracture of the radial neck, but it's just slightly outside of that joint capsule, meaning it doesn't get involved. Now, a bit of a pro tip as well is that when you do get extensive injuries where someone's fallen on their outstretched hand, you also want to have a look at that process over here, the coronoid process sitting over here. You want to make sure there's no evidence of a fracture, because if you have a fracture of this, that means that there is the ability of that whole elbow to slip out, and you actually get a very unstable joint. So this happens a lot actually, where someone has something called satisfaction of search. It's a phrase that radiologists use, where you see an abnormality, you think, yeah, I've done it, I'm going to move on, and then you move on. But actually, a lot of the job for radiologists is just to look for the next finding, because what they say, I guess, is that the most commonly missed fracture is going to be the second fracture, because everyone kind of gets all happy you've seen the first fracture, but it's the second fracture that gets missed. And that's the thing that you need to be looking for with these things. But in this particular occasion, we don't have a second fracture. What we have is that only primary fracture sitting over here, which is going to be that radial head. Right, and obviously we've got that joint effusion as well.